Hey, good morning, everybody. Thank you so much for joining, those of you who are here in person and those of you who are here on Zoom. Thank you so much, Andre, for that nice introduction. It is really exciting that we're having our BOP seminars in person again. This is one of the first in person since the pandemic. And as was mentioned, this is the first time that at UCSF we are celebrating Global Lobular Breast Cancer Awareness Day. And the purpose of this day really is to raise awareness of lobular breast cancer. And I hope that we will also pique your interest, those of you who may be less familiar with it. Perhaps there will be something that you want to start investigating. So my goal in the next 10 minutes is to give a brief overview of the unique clinical and biological features of lobular breast cancer, and to give you an overview of what we have been doing in the last few years as we have really been establishing a lobular breast cancer research program here at UCSF, and talk about some of the future goals. And then we're going to have 4 speakers, 2 of which are really going to be focusing on some of the diagnostic and clinical issues around lobular breast cancer, and 2 of whom are going to be talking about some of the research that is going on here at UCSF. So lobular breast cancer is the second most common histologic type of breast cancer after invasive ductal carcinoma, which is now called carcinoma of no special type. Lobular breast cancer makes up 10 to 15% of all breast cancers. And as was mentioned by Andre, it's really characterized by the fact that it is missing the adhesion protein E-cadherin. And this leads to a diffuse growth pattern. And this is believed to lead to lower sensitivity of mammography. So it can be harder to detect this. And we're going to hear a lot about both of these topics from our first 2 speakers, Dr. Ye and Dr. Price. Most lobular breast cancers are molecularly low risk. So if you were to get an assay like MammaPrint or Oncotype, the majority will be low risk. And that's also reflected in the fact that the majority are also ER positive, HER2 negative, and they're often of low or intermediate grade. There is a propensity for late recurrences in lobular breast cancer. And compared to ductal breast cancer, the metastatic pattern is different. So lobular breast cancer has a tendency to metastasize to the gastrointestinal tract, the lining of the abdomen or the peritoneum, the ovaries, and the orbit or the eye. Because of the difficulty with seeing this on screening mammography, people with lobular breast cancer are actually diagnosed at later stages with larger tumors and higher rates of nodal positivity. And this really impacts the clinical outcomes. So when it comes to surgery, we see higher rates of positive margins, more re-excision surgeries, more mastectomies, more axillary dissections, and this really leads to greater morbidity for patients. There are some challenges with selecting the optimal systemic therapy for patients with lobular breast cancer. We see lower response rate to neoadjuvant chemotherapy, and there have been some persistent concerns about possibly differential responses to certain types of endocrine therapy among patients with lobular tumors. We also have suboptimal surveillance strategies for patients who have been treated for lobular breast cancer. These data are from the National Cancer Database, and this is looking at the rates of pathologic complete response in patients with lobular versus ductal breast cancer. And you can see that for patients who are treated with neoadjuvant chemotherapy, only 8.7% have a pathologic complete response compared to 23% amongst those with ductal breast cancer. This may also be related to the fact that more patients with lobular tumors have ER positive and HER2 negative disease. The subset of patients with triple negative or HER2 positive lobular tumors do have higher rates of pathologic complete response. But one of the challenges really is reflected in this slide here, which shows the discordance between clinical risk and molecular risk. So clinical risk is really referring to the size of the tumor, the number of positive nodes, and molecular risk is referring to genomic assays such as MammaPrint or Oncotype, or the biologic features of the tumor that would suggest whether or not a tumor might respond to cytotoxic chemotherapy. And in the red box, you can see that for patients with lobular breast cancer, 35.6% fall into this discordant group where their clinical risk is high, but their molecular risk is low. And that discordance can make it very difficult to determine what is the best treatment strategy. This is a recent paper looking at recurrence risk in patients with lobular breast cancer compared to ductal breast cancer in some of the original NSABP trials. And on the left, this is looking at the rates of early recurrence in the first 5 years after diagnosis. And patients with lobular breast cancer tend to have fewer early recurrences compared to those with ductal cancer. But on the right, you can see that if you follow these patients for long enough, they actually end up catching up and exceeding the rate of recurrence seen in those with ductal breast cancer or carcinoma of no special type. And this is true regardless of ER status amongst those with lobular cancers. And this picture here, I think, illustrates the way that I kind of think about lobular versus ductal breast cancer. Oftentimes, people talk about lobular breast cancer as being kind of slow growing and indolent, but just like with the story of the tortoise and the hare, even a slow growing cancer can be difficult to stop. These cancers can just continue to plod on step by step and eventually really cause problems in terms of recurrence for patients. Finally, the rates of lobular breast cancer are increasing across all ethnic groups. This is a slide or a graph from a recent SEER database analysis that just came out in the last week or two, showing these increasing rates of the diagnosis of lobular breast cancer. So after discussing some of these clinical features, I want to give you guys a small flavor of some of the biologic differences in lobular breast cancer and some of the possible treatment targets. So we'll go through these rather quickly, but I want to highlight some important papers. This paper that was published about 10 years ago established 3 different molecular subtypes based on gene expression signatures within lobular breast cancers. I've highlighted the names of some of our colleagues here at UCSF who are part of this important TCGA analysis. They were able to show that within lobular breast cancer, these tumors can be divided into what's called reactive-like, immune-related, or proliferative. And these gene expression signatures are associated with differences in disease-free survival and overall survival. Another group in Australia has identified a gene expression signature called LobSig, and this is also able to prognosticate amongst patients with lobular tumors to predict their recurrence-free and overall survival. Data show that lobular tumors have a different pattern of mutations compared to ductal tumors. So in lobular cancers, we see higher rates of mutations in the genes CDH1, AKT, FOXA1, and HER2. And there are actually 2 ongoing neoadjuvant trials specifically for patients with lobular tumors that have either AKT mutation or HER2 mutations. Alan Ashworth and Chris Lord have actually done important work showing that there is a synthetic lethality between a drug called ROS1 inhibitors and tumors that are E-cadherin deficient. And this has led to ongoing clinical trials in both the early stage and metastatic setting, testing ROS1 inhibitors for patients with lobular tumors. LOXL1 has been identified as another potential treatment target, specifically in lobular breast cancer. And finally, the Rho-ROCK pathway has also been identified as a potential treatment target. E-cadherin loss, which is the characteristic finding in lobular tumors, leads to loss of P120 at the membrane. P120 becomes cytoplasmic, and this leads to upregulation of the Rho-ROCK pathway and allows these cells to survive despite being anchored to any surface. So Rho-ROCK inhibitors are also potential specific treatments for patients with lobular tumors. So I hope that this brief overview has convinced you that lobular breast cancer is a unique tumor type with suboptimal outcomes and has a need for focused research. Here at UCSF in the last few years, we started looking at lobular breast cancer, and we began by focusing on clinical questions like what techniques are associated with positive margins? Can we do re-excisions if someone has a positive margin? Can we do nipple-sparing mastectomies? Is chemotherapy associated with improved survival when you have that discordance between clinical and molecular risk? Does HER2 low status confer worse outcomes? So we started by really looking at our own data, and we have created an institutional database for every patient who's had surgery for lobular breast cancer here at UCSF. And we have really curated treatment and outcomes data from more than 1,000 of these patients. We've also looked at some of these questions in the National Cancer Database and developed a prospective registry study for patients with lobular breast cancer. So these are all resources that we can continue to develop and utilize as we try and answer some of these clinical questions. So far, we've been funded by the American Cancer Society, the National Cancer Institute, institutional funding through RAP grants, and we were recently funded by the Mediviver Foundation. We've been productive with 45 papers published on lobular breast cancer in the last 5 years, really looking at these issues of local regional outcomes, systemic therapy, recurrence, surveillance, and disparities. But we do really want to move towards prospective research. And we have conducted a prospective imaging study looking at dedicated breast PET with fluoroestradiol in patients with lobular breast cancer. We have ongoing work looking at lobular tumors in the I-SPY 2 trial. We're working with our pathology colleagues, so Yunyi Chen, Juliet, and now Sandy, on creating a tissue microarray of ILC cases, sequencing these cases. And we've recently started a prospective multicenter study called the PLUM study. And this is looking at serial circulating tumor DNA in the setting of patients with metastatic lobular breast cancer. We have many multidisciplinary collaborations ongoing with breast imaging, nuclear medicine, pathology, surgery, medical oncology, radiation oncology, genetics, and importantly, biostatistics and epidemiology. And we are also going to be hosting the International Lobular Breast Cancer Symposium here at UCSF, sponsored by the Department of Surgery and the Helen Diller Family Comprehensive Cancer Center. And we'll have more information at the end of this session for you guys about that. So lobular breast cancer is a common subtype of breast cancer with unique features. We do have a robust program that we're developing and which is recently expanding here at UCSF. We would like to have ILC-specific clinical trials. We'd like to see basic scientists here at UCSF studying lobular breast cancer. And the ultimate goal is to understand how to predict who's at risk for lobular cancer, the optimal way to prevent, detect, and treat it. So today we're going to have 4 speakers talking to us about lobular breast cancer pathology, imaging, and then sharing some recent data on circulating tumor DNA and tumor organoids in lobular breast cancer. So thank you very much, and I'll call up Julia.
Thank you so much for the introduction, Rita. My name is Julia Yi. I'm one of the new breast and cytopathologists here at UCSF, but I've actually been around since 2010 when I started as an MSTP student. I'm here to represent the UCSF breast pathology group today and to talk about our perspective, the pathologist perspective on invasive lobular carcinoma or ILC and the challenges that we face in diagnosing this entity. So as we've already heard, when we talk about breast cancer, we're usually referring to invasive ductal carcinoma or IDC, which makes up about 3/4 of all cases. ILC is, or invasive lobular carcinoma, is the second most common type of breast cancer and the most common special subtype of breast cancer, making up 10 to 15% of cases. Classic ILC has a very classic morphology on histology. It's characterized by discohesive tumor cells that are individually dispersed or arranged in linear single file patterns. The tumor cells are small. They can have intracytoplasmic vacuoles, and they're not mitotically active. And there's usually not much of a stromal response. Okay, that sounds pretty straightforward. The problem is there are actually many different histologic variants of ILC. In fact, more than 10 different variants have been reported in the literature. And studies suggest that these variants account for anywhere between 30 to 70% of ILC cases. Importantly, some of these variants, like the alveolar type, the trabecular type, the solid papillary type, and the tubular elements type, look a lot like IDC. And you can imagine that these can really present some major diagnostic pitfalls. So maybe it won't surprise you too much to learn then that although pathologists typically regularly recognize and report classic and pleomorphic ILC. The other subtypes are less frequently reported. And this was demonstrated in a worldwide survey of 147 pathologists that was performed by the European Lobular Breast Cancer Consortium and published in 2022. So what this means is that the publicly available ILC databases may not actually capture all the ILC variants. Okay, so you're probably thinking, can't we just use E-cadherin to make the diagnosis? So as a re-review, E-cadherin is a member of the adherens junction complex, and along with the catenins, P120 catenin, beta catenin, and alpha catenin, E-cadherin helps to enable cell-cell adhesion. Mutations in the CDH1 gene, which encodes E-cadherin, were discovered as the oncogenic driver in ILC in the 1990s, and biallelic loss of E-cadherin is thought to explain the dyscohesive morphology in ILC. In clinical practice, we use E-cadherin IHC or immunohistochemistry and P120 catenin immunohistochemistry side by side. So in normal breast tissue and in invasive ductal carcinoma, ECAD and P120 both show membranous staining, shown here. But in ILC, the textbook appearance is that E-cadherin is negative and P120 shows cytoplasmic staining. All right, that sounds straightforward. The problem is the World Health Organization classification of tumors actually does not require use of ECAD IHC to make a diagnosis of invasive lobular carcinoma. If you read the guidelines, it says that ECAD loss is a desirable diagnostic criterion, not essential. And I think there's some good practical reasons for this. One is that the WHO is meant to be used around the world, and IHC is not available around the world. The second one is that there are many potential pitfalls to interpreting ECAD IHC, which I will discuss in the subsequent slides. But there are a couple of really important implications to this non-requirement of ECAD. The first is that because only about half the pathologists worldwide regularly use morphology and ECAD systematically to diagnose ILC, this means that a subset of the ILCs in the literature in the public databases do not have a CDH1 mutation. The second very important implication is that the diagnosis of invasive mixed ductal and lobular carcinoma means different things depending on who is your pathologist. So for example, if you have a pathologist who takes a purist view, they're making this diagnosis when part of the tumor looks very cohesive, like IDC, and the ECAD is intact, and a different part of the tumor is very dyscohesive, looks like ILC, and ECAD is negative. But if a pathologist takes an alternative view, you might get this diagnosis when the whole tumor looks pretty cohesive, like IDC, ECAD is intact throughout, but there are just some areas in the tumor that demonstrate this linear single file growth pattern, this so-called ILC-like growth pattern. Now, neither of these approaches is wrong or right per se. It's just important to be aware of this difference or this variability in diagnostic practice. Okay, so let's assume that ECAD use is not controversial and everyone is using ECAD IHC regularly. Even then, we still face challenges because not all E-cadherin antibodies are created equal. In fact, there are 11 different ECAD antibodies that are used in clinical practice worldwide. And there's this paper that was published just last year in 2024 that looked at the performance of 5 of the most commonly used ECAD antibodies in clinical practice. You can see them diagrammed here against the ECAD protein, see where they bind. What the study showed that some of these antibodies show non-specific binding on Western blot. You see the clone 36 NCL and the EP700Y. And one of these clones, the clone 36, even shows binding to p-cadherin. They also compared the IHC staining qualities of these clones side by side, and you can see there's quite a bit of variability in how the staining shows up. And they also discussed how use of different staining protocols and staining platforms can also affect the performance of any one of these antibodies. The conclusion of this study was that the ECH6 and NCH38 antibody clones were the best IHC performers. And you'll be glad to know that SFGH and Stanford both currently use NCH38, and UCSF is currently getting NCH on board. Okay, there's still more problems with ECAD IHC, and it's that it's not always completely negative in ILC. It can show aberrant staining patterns, cytoplasmic staining, nuclear staining, dot-like perinuclear staining, complete but weak membranous staining, fragmented focal or beaded membranous staining, and all of these aberrant staining patterns should be considered indicative of a loss of function in the E-cadherin protein. But as you might imagine, how exactly this aberrant staining turns up depends entirely on what antibody you're using and what staining platform you're using. It can also depend on what kind of CDH1 mutation you have. So as a really interesting and kind of extreme example, there have been reports of this rare missense mutation, this S180Y, that occurs in the extracellular homotypic binding domain of ECAD, and this results in a loss of function of the ECAD cell-cell adhesion function, but ECAD continues to be localized to the cell membrane, and therefore ECAD IHC and also P120 and beta-catenin all continue to show membranous staining. So the important takeaway is that these aberrant staining patterns of E-cadherin can be misinterpreted as positive E-cadherin staining. You're probably sick about hearing about ECAD by now, so let me leave you with one last challenge that we face in ILC pathology that has nothing to do with ECAD, and it is that ILC is difficult, if not impossible, to visualize on gross exam. While IDC often presents as a grossly visible mass, ILC is often grossly occult, meaning that the tumor size that we determine by looking at slides under the microscope is often greater than what is estimated based on radiologic appearance and what we saw grossly. Here's an example of a partial mastectomy specimen from someone who had ILC that we thinly sliced into 20 sections. And you can see that the grosser thought they could appreciate tumor beginning in slice 7 and going all the way to slice 15. But when we submitted all the tissue sections for microscopic review, we found that there was tumor extending all the way from slice 5 to slice 17. So what this means is that in pathology, we have to submit many more tissue sections to accurately determine the size of ILC cases than we do for IDC cases. So in conclusion, I hope I've given you a sense that although classic ILC is conceptually straightforward to diagnose, there are many challenges in the pathologic evaluation of ILC, which I have briefly touched upon. And I believe that increased awareness of the potential pitfalls in the pathologic evaluation in ILC will help us conduct more robust studies of ILC biology and ultimately improve ILC-directed care for patients. Thank you for your time.
Thank you so much. Our next speaker is Dr. Elissa Price, one of our radiologists here.
Thank you, Rita. I'm really thrilled to be here and be part of this very special day and share with you a radiologist perspective on ILC. I'll go through a number of our imaging modalities and the challenges that we face in this unique tumor type. As we have heard, ILC has a very unique pathology, and what we see on imaging is a natural reflection of that unique pathology. This unique linear growth pattern that we've heard about, well, that's what we see on imaging, and that means that more often ILC presents as things other than a mass. Now, when I say more often, I mean compared to the other tumor types. At the end of the day, I have 2 asterisks here, and that is because common things are common, and the most common ILC presentation on imaging is still a mass. But that being said, there are other ways that ILC presents that are more unique. So mammographically, the common ways ILC presents are mass, architectural distortion, and developing asymmetry. And we'll go through all of these. We're going to do a lot of cases. I'm a radiologist, but I will never ask you anything. I'll always show you what I'm looking at. This is a screening mammogram where ILC presented as a traditional mass. So for those of you not familiar with mammography, MLO is a medial-lateral oblique. The breast is squished at approximately 45 degrees. CC is a straight down compression like a pancake. And these are our 2 standard mammographic views. And what the arrow is denoting here is a mass. It looks like a little golf ball put in the breast. It's very white and has convex borders. And this on biopsy proves to be ILC. Here's a different case of a woman who presents for screening. And this time, ILC presents as distortion. Distortion is lines radiating from a point, so not a big white ball. These are the side-to-side pancake views, the straight down. And what we see here as radiologists is this very subtle pulling of the tissue. There's not a ball there. This is architectural distortion. These are the MLO views, the other standard screening images. Incredibly subtle finding of pulling, lines coming together, not a mass. This was noted on the screening, and the patient was brought back for focused pictures. Even focusing in on this area, it's incredibly subtle to identify these lines coming together, and that's distortion. Here's ILC presenting as a developing asymmetry. Developing asymmetry kind of looks like tissue. So the black here is fat. The white is normal fibroglandular tissue. And what you see here is this sort of pat. It kind of looks like the other fibroglandular tissue. It's just kind of hanging out on its own. And this is the real challenge for us. Is this normal? Like, not everyone's perfectly symmetric, or is this pathology? When we evaluate it, these are concave borders, not convex. And there's all these little black holes in this area. That's fat. Nothing about this is a mass. So it certainly doesn't fit our criteria for a mass. Here's the other view, and just optically magnifying that for you. Again, there's fat within this lesion. This is not a traditional mammographic mass. And yet on biopsy, this is cancer. So after seeing something on mammography, we go to ultrasound. Some of you probably haven't seen a breast ultrasound before. This line at the top that is sort of horizontally oriented, that's the skin. And the rest of it is more or less all breast tissue. And what you can see here is a sort of what we call mixed echogenicity, some areas of darkness, some areas of whiteness. That's a big mass disrupting the normal breast tissue. And on biopsy, this proves to be ILC. Here's another patient. She's had a history of a right lumpectomy, and now she's presenting for her screening. So we said she's had a lumpectomy. This is what scarring looks like on mammography. This patient has already had surgery. Some eagle eyes in the audience might notice there's something else there. This little metallic structure is a biopsy clip. So this patient has been through surgery. She's also had a biopsy. All of that proved to be benign. The problem is this. Now, again, it doesn't look like a mass. If anything, it looks like a little patch of tissue. Has concave borders, not a mass. But this was new, and we need to evaluate it. In this case, again, we go to ultrasound. And this, unfortunately, is a common thing with ILC, where there is actually no sonographic correlate at the time of ultrasound. That doesn't mean we ignore the mammographic finding. We just have to pursue this using a mammogram-guided biopsy, and this also proves to be ILC. So that's a nice segue into talking about ultrasound for this unique pathology. And the problem is, ILC on ultrasound can look like anything or nothing and still be present. So that's tricky. In fact, I've already shown you ILC presenting as a mass, mixed echogenicity. ILC presenting with no sonographic correlate, and ILC, I'll show you in a moment, presenting as a very traditional sonographic mass, very black, very round, convex outwards borders. So that's the challenge with ultrasound. Let's move to MR. Now, we use a lot of MRI at UCSF for ILC. Occasionally, that's to diagnose it in the setting of a screening MR, very often used for extensive disease. And that is because of all our imaging modalities, MRI has the highest sensitivity. And so this test allows us to demonstrate that ILC is actually more frequently than other cancers multifocal. That means more than one site involved in a single quadrant, or multicentric, more than one quadrant involved in the same breast. MRI also shows us that this disease is more frequently bilateral than other types of breast cancer. So here's an MRI. Some of you might not have seen this before. I've labeled left and right. The black, the darker areas are the breast fat. MRI, unlike mammography and ultrasound, is a contrast-enhanced exam. So the patient gets an IV, dye is injected, and that allows us to get some functional information. Anything you see here that is white is either breast tissue or vessel, and those are our areas of interest. And I'm sure you've noticed it looks like someone plopped a little sunburst into the left breast, and that is ILC presenting as a spiculated mass. With the unique linear pathology of ILC, we see other things on MR beyond masses, and this is a different type of pathology we see called non-mass enhancement, and it very sort of nicely illustrates that infiltrative linear growth pattern of ILC as we see here and here. Let's go through some cases. Here's a 53-year-old woman who presented with a palpable lump. So when a patient presents with a palpable lump, we put a little BB on her skin before we image her. That's what this is. Then we look at the mammogram, don't see anything there. even when we take focused pictures of that specific area, the mammogram does not show a problem. We go to ultrasound and see the mass I showed you already. This is not a small mass. This is over 2 centimeters on ultrasound, occult on mammography, biopsy-proven ILC. So we're going to go to MRI to understand the extent of disease in this case. And we do that a lot. We call them EOD exams. And so in this case, here's the tumor. It's white because it picks up the dye I talked about. And it's just over 2 centimeters, as we thought on ultrasound. You may notice this black ball on the inside of it. That is the biopsy clip. We saw one of those on mammography a few minutes ago. They look black on MRI. So this we know for sure is the site of cancer because that's the biopsy clip. That matches the ultrasound. But what we also saw in MR is all of this enhancement in front of the mass and even some enhancement behind the mass for a total MRI extent of abnormality of over 5 centimeters. So well more than double what we suspected on ultrasound. We suspected nothing based on the mammogram. So MRI really changing the amount of disease we're suspicious for. Here's another patient. She has known left ILC, gets an MRI for EOD. This is what's called a MIP, a maximum intensity projection. This is like a 3D rendering of all the slices from the MRI. And this is the patient's cancer. And even not being a radiologist, I bet you can look around that and see like many, many more little masses throughout that left breast, and in fact, in the right breast. And when we start looking at the source images, here's her cancer, and then there's this, and this, and this, and this, and all of this. And on the next slice, there's all of this. And these cases are a challenge. And this is very much the kind of case that proves not only what a challenge it is, but how important it is to have a team of people who work in ILC. With this kind of case, I would call Dr. Mukhtar, say, I need you to come, and we need to look at this case together. And we would try and understand what we're looking at and how we can help this patient best. In this case, this proves to be bilateral ILC. Another patient, known left ILC, MRI for EOD. What I want to draw your attention to is her right breast. This is a normal breast. And I've just sort of delineated the AP front to back extent of her breast and medial lateral. Just that's what her normal breast size is. Now look over. Look how big her left breast where the known ILC is. It is way bigger than her normal breast. And that is because it is entirely infiltrated and expanded by this ILC that has managed to intersperse itself throughout her breast tissue and cause a larger breast than contralateral. The very last imaging study I want to show you is on a patient who's had a remote right lumpectomy, and she presents for annual screening. And in her, we use the new kid on the block, contrast enhanced mammography. So this test, the patient gets a traditional mammogram, but stealing something from MRI, she also gets an IV and she gets a dye injection. And so we do both traditional mammography and some contrast enhanced examinations. Here's her traditional mammography. There's some scarring here in the right breast, and that is normal. She's had a right lumpectomy. Her mammogram has looked like this for years. This is her right lumpectomy scar. When we give the dye, the breast should go very quiet, as you see screen right. But what we see here is a huge area of abnormality, completely not identified on traditional mammography. On both of these views, you can see it's sort of more prominent at the front, has this tail going out to the back. This proves to be ILC. So we get an MRI for EOD. And I think it just so nicely demonstrates the cross-modality correlation. Here's the abnormality on MRI. It looks exactly like the abnormality on contrast enhanced mammography, more prominent at the front, tailing out to the back. And we'll finish up. I don't do any systemic imaging. I'm solely a breast imager. Dr. Mukhtar already reviewed with us that although traditional breast cancer goes to nodes, liver, lung, ILC has some other places that we need to be cognizant of: brain, skin, reproductive tract, ocular pathways, pleura and peritoneum. And speaking of new kids on the block, there's this very exciting technology, FES PET, where systemically metastatic disease can be identified that is otherwise occult. And that's very new, just added to the NCCN guidelines this year in 2025. So finishing up with some new technologies that I think might help our ILC armamentarium and some of the challenges we face. And I'm happy to take questions and chat during the discussion later. Thanks.
Thank you so much, Elissa. That was great. Our next speaker is Dr. Mark Magbanua, who will be talking to us about circulating tumor DNA and lobular breast cancer and the I-SPY trial.
Good morning, everyone, and thank you, Rita, for this invitation to discuss our collaboration focused on understanding the clinical significance of circulating tumor DNA in invasive lobular cancer. And I would like to thank the I-SPY2 cDNA working group, and also Nagel's man, who has helped in the analysis of the data. So here's the outline of my talk. I'm going to define circulating tumor DNA, talk about studies in metastatic ILC, as well as an early stage focus on the I-SPY2 data, and compare cDNA in ILC versus invasive ductal carcinoma, and touch on the prognostic value of circulating tumor DNA in ILC, and provide you with a summary and future directions. So circulating tumor DNA is a small fraction of the cell-free DNA, the DNA that's floating in the blood. And most of the cell-free DNA that is in the blood is actually coming from dying hematopoietic cells. And the fraction of circulating tumor DNA in the blood of a patient, it is dependent on many factors. Some of them are unknown, but it's usually correlated with the subtype or the size, tumor burden of the patient. So how do we find circulating tumor DNA in the blood? So we find Waldo in the midst of all these people, the crowd, using the signature clothes that he wears. There's also signatures that we use for circulating tumor DNA, that is the genetic information or the mutation that are present in the underlying tumor that's shedding the circulating tumor DNA. So you see all these different types of mutations that are not present in the cell-free DNA that is shed by hematopoietic cells, which are wild type, right? And and we use that also not just for detection, but also for quantification. So there's not a lot of studies in cDNA in ILC. It's a very early field of study, and so that's why I'm really excited to be working with Rita on this. And there's only a few papers that have covered this topic. And one of this is here showing some evidence that in blood using the Guardant 360 cDNA assay that you can see a lot more mutations in the ECA adherent gene as compared to the breast tissue in TCGA. Of course, this is not a definitive conclusion because they're not paired samples, but it would be better if we look at this in a paired sample, which we have an opportunity in our studies that we're trying to do with in the plum, which already Rita has mentioned earlier. So here's another study, a more recent one by Dr. Faldi and colleagues, and here they look at real-world data circulating tumor DNA using the Signatera test. It's a small number of patients, 66 with 355 samples, and they showed that increase in cDNA levels is associated with disease progression. So it's not surprising that is the case, and we see that also in invasive ductal carcinoma. You can see that there's an increase in cDNA levels, there you can see a corresponding increase or a corresponding documentation of progression in the patient. Also important to point out here is the positive predictive value of circulating tumor DNA, which increases exponentially with each positive cDNA positive result, and it's the reverse for the negative predictive value when the cDNA test is negative. So as you know, or many people know, there is a strong program for circulating tumor DNA studies in I-SPY2. In I-SPY2, blood is collected at pre-treatment week 3, which is T1, week 12, T2, and T3, which is after neoadjuvant therapy. And the endpoints are the response, which is RCB0 or pathologic complete response, or no PCR corresponding to 1, 2, and 3, and the survival endpoint is distant recurrence-free survival. And in the I-SPY2, we use also the Signatera test, which I mentioned earlier. it's a tumor-informed test which uses whole exome sequencing data to find mutations and uses that information to design targets to detect cDNA in the plasma. So here's the cohort that we have. Of the 714 patients with cDNA data, 65 had ILC and 9%, which is consistent with what in the population of 10 to 15%. I just wanted to point out here a common two data points here where there is a significant enrichment of hormone receptor positive, HER2 negative, which we expected relative to IDC, around 72%. And also the RCB0 or the pathology complete response is much lower compared to IDC, 20% compared to 35% in this cohort. So we found that cDNA positivity and concentration was lower in ILC versus IDC, around 68% at pretreatment positivity, and as opposed to 83% in IDC. And also the median concentration, mean tumor molecules per mil, was also significantly lower. But this is probably because there is an enrichment of the hormone receptor positive HER2 negative, which across different subtypes have lower incidence of cDNA positivity and also concentration in the blood. So that's why when we control for subtype in this logistic regression analysis, we lose that it's the significance, we lose the significance, but it's still, a trend towards lower cDNA positivity in ILC versus IDC. Interestingly, we did not see any association with clinical pathologic variables between cDNA positivity and concentration at pretreatment. The clinical pathologic variables that we examined are subtype, clinical T-stage, clinical end-stage grade, and mammoprint. And this is why I say is interesting is because in IDC there is strong correlation between this cDNA positivity and concentration at pretreatment and this clinical pathologic variables that we usually examine in I-SPY 2. However, if we look at the prognostic value of cDNA status, in this case, we look at positive or negative at T0, T1, T2, and T3, that's week 3, 12, and post-neoadjuvant therapy, we see a strong signal of cDNA positive patients having a worse DRFS compared to those who are negative. So in T3, we know that those are cDNA negative who perform better are actually composed of patients who are either persistently negative or have cleared at T1, T2, or post-neoadjuvant therapy. So it's important to look at cDNA dynamics. And when we look at cDNA dynamics, and this is actually only focused on no PCR, patients who did not have a response, because patients who have a good response or a PCR have very favorable survival. So we wanted to ask whether can we further risk stratify patients who did not have a PCR using cDNA dynamics. And we find that those who are persistently negative are much better off compared to those who clear later or no clearance. Of course, this is a very small data set. You can see that the confidence intervals are huge, but regardless, there is already this signal that we're seeing even in this smaller cohort. So to summarize, cDNA in early stage and metastatic ILC, these studies are still ongoing. It's a very underexplored area of research. And then I-SPY 2 actually provides this opportunity to study ctDNA in early stage high-risk breast cancers. So we did not see we saw a lower cDNA positivity rate and concentration in ILC versus IDC, but it's probably because of the enrichment of the hormone receptor positive HER2 negative subtype in the cohort. And what is important to show that we have shown or we've observed is that the CNA status and dynamics, despite the limitation that I point in the last bullet point here, is that we still see the prognostic value of the of CDNA for predicting distant recurrence-free survival. So what are our future directions? So we want to see whether ctDNA is predictive of response in ILC. This is important because, as I noted, and other speakers have noted, that the ILC have a poor response to neoadjuvant therapy, and can we use ctDNA to guide treatment or to monitor treatment response in the context of the neoadjuvant setting in I-SPY 2? Another important thing to ask is the clinical significance of circulating tumor DNA in MammaPrint low-risk ILC. So as in I-SPY 2, they're all high-risk, MammaPrint high-risk. But we also have a program led by Joe Chen, who's in the audience, the Endocrine Optimization Project, which is enriched for invasive lobular cancer, where we can look at the clinical significance of ctDNA in this cohort. And most importantly, we want to also see whether there are other platforms there for ctDNA detection, because right now it's only a 34% detection rate at pretreatment in the EOP study. And also, of course, important to note is the PLUM study that is led by Dr. Rita Mukhtar, to look at the clinical utility of circulating tumor DNA in longitudinal analysis of circulating tumor DNA compared to imaging in the metastatic setting. So with that, I'd like to thank I-SPY 2 for providing us this opportunity to study ctDNA in this cohort, Laura Esserman and Laura Van Weer, especially in all the patients who participated in this study. Thank you.
Thank you so much, Mark. Our final speaker before our discussion is going to be Dr. Jennifer Rosenbluth.
Hi, everyone. Thank you so much for the invitation to speak on Global ILC Awareness Day. I will also start with E-cadherin, which, as we've heard, is a key molecule mediating cell-cell adhesion in epithelial tumors and epithelium. And it also binds to key signaling factors and keeps them at the cell membrane, thereby preventing them from going off and activating invasion and metastasis pathways. And E-cadherin levels really correlate with the biology of spread of different types of breast cancer. So as we've heard, for invasive lobular cancer, E-cadherin is lost, and these cells grow and spread in a single file or less cohesive manner. In invasive ductal carcinoma, due to E-cadherin, these cells can actually invade in small clusters of tumor cells, and they spread in that manner. And then there's a rare subtype of breast cancer, inflammatory breast cancer, where E-cadherin is actually increased. And so those cancers actually spread as massive tumor emboli and are able to invade in lymphatics this way. So it's clearly a key player. And because of this, when we thought about trying to grow invasive lobular carcinoma in the lab, we really focused on E-cadherin, and we thought E-cadherin loss, as well as this discohesive growth pattern, should characterize most of our ILC model systems. Now, there are some cell lines and PDX models for invasive lobular carcinoma that do exhibit E-cadherin loss and this discohesive growth, but they're pretty limited and are generally from metastatic tumors. So there is a need for more model systems. And the way we approach this is through organoid culturing. So we try to maintain tumors as sort of mini tumors on a dish in the lab. We do this by collecting tissue samples that are viable from radiology and pathology, and about most of our tissue samples come from the operating room, where a tiny piece, a core biopsy, is removed and mechanically or enzymatically dissociated, then embedded in a basement membrane extract and given nutrients to allow those cells to grow so that we can then test drugs and model that disease. And I'm really grateful to collaborate with all the surgeons and pathologists, radiologists for this, but for this talk, I wanted to especially highlight Laura Esserman, with whom I set up this protocol here, and then also Rita, who has really constantly encouraged us to grow and model ILC using this system. There are other groups who are recently, I think, working on ILC organoid cultures. I just wanted to mention who have presented recent successes. And so one group is at University of Pittsburgh, and they recently presented 9 ILC models at AACR, where they're able to grow and validate some models that have some unique features that are reminiscent of ILC. Also, the Spectre Lab at Cold Spring Harbor at San Antonio recently presented ILC organoids, and they were also in Hans Cleaver's original publication on breast cancer organoids, where they do have a more discohesive growth pattern, really look different from other organoid models. I think also reported that it's more challenging to culture ILC as compared to other breast cancer types. So we went and looked back at our experience working here at UCSF in the breast oncology program for the past 4 years, establishing this breast cancer organoid biobank, a wonderful collaborative effort where we're able to culture normal breast all the way to invasive breast cancer, trying to align with different initiatives that are very exciting here at UCSF and hopefully foster collaborations. When we looked back at our ILC organoids, we did right away notice some challenges with this particular organoid type. So where we were expecting to see discohesive organoids with e-cadherin loss, we were really seeing more of a mixed picture. And so many of our cultures had cohesive spherical growth, or a mixed feature where there's some discohesive cells and then some cohesive, more classical organoid appearance. We thought, we heard from Julia that this is actually more complicated, and I learned from her talk about this is pretty complicated. There is mixed ductal and lobular carcinoma, and we really thought that we could have different hypotheses about homogeneous versus heterogeneous loss, but we expected to see more homogeneous loss. And we can see this when we look at e-cadherin levels as well, here quantified by flow cytometry for an ILC organoid, where we see 2 populations within that one organoid culture from a single patient's tumor. We can see both e-cadherin low negative cells and e-cadherin positive cells within that same tumor culture. So we researchers and wondered why this could be, and one of the things we wondered is whether our culture system was really promoting growth of more of a ductal phenotype, or that subclone within the tumor. And part of this might be because we're growing them in a extracellular matrix that's really basement membrane. So we're surrounding those cells with basement membrane, and they grow as a 3D sphere where the whole thing is surrounded by basement membrane. That's what epithelial cells align themselves on and grow on, and might promote cell attachment and growth in that kind of fashion. So we recently started using a new approach in the lab that's really spearheaded by Jose Sedano, a new graduate student in the lab, and was developed by Calvin Kuo at Stanford, which is the air-liquid interface culture. And what Jose was able to do working with Nadine was really sort of add some of the approaches that we were using with our more traditional organoid culturing to that system, and I think sort of enhance that culture system for breast. So traditionally, we're doing submerged cultures where our tumor epithelium is grown, again, in that basement membrane dome, and then with media surrounding it that maintains breast cancer stem cells and other cell types. What the air-liquid interface does is it uses a collagen disc. So this collagen disc is in an insert sitting on top of that medium with a semi-permeable membrane so that the nutrients can get to that disc, and these tumor fragments are there. And so the collagen is more of the matrix that's in between the ducts and lobules. So this might be more reminiscent of the material that those invasive lobular carcinoma cells are actually invading through. And so we thought this could be a good system to try, particularly for ILC. And the other thing that we're really excited about with this system is that you can modify the medium so that you can keep stromal elements like immune cells alive for longer in culture, which Jose has been able to demonstrate. And as we heard, there can be an immune infiltrate in ILC. So that's also an important aspect. So first, Jose benchmarked this with normal breast epithelium, which is where we started as well in organoid cultures, and he found that he was able to maintain breast organoid growth, collaborating with Julia to look at these with a hyperplastic phenotype, because again, we are trying to get these cells to grow. We need them to expand so that we can study them in the lab. And so he was able to show pretty well maintained architecture in these, as well as basal and luminal polarity, which is expected with normal breast tissue. So we were really happy to see that. And he's just started growing invasive lobular carcinoma organoids, but we are encouraged that they do look different from our other organoids, and we think that there's different growth patterns that we're seeing from these very initial cases, and we think they might be less cohesive, although I think we'll have to do more culture more cases to really see. And we are able to see low or no EC adherent staining when we stain these culture systems with EC adherent by immunofluorescence as compared to normal breast tissue here. So what do we want to do with these ILC ALI organoids once we establish them? So one of the things we're really interested in is being able to test different types of endocrine therapy. As a medical oncologist, there's more and more endocrine therapies, many new types that are coming through the pipeline for breast cancer. And we know that ILC is a very ER positive breast cancer type, but with seemingly different features in terms of ER signaling. And so it'd be exciting to be able to test those. We've done this working with the EOP that we've heard about, the endocrine optimization protocol, and iSpy, working with both IDC and ILC from that trial. And Shruti Warhadpandi and Nadine Goldhammer in my lab developed a system that allows them to sort of reset the organoids so that they can actually assess estrogen receptor activity in these cultures. They can treat them with estrogen now and see an ER-dependent activation of target genes, which was not something we were able to do before. For this project, Laura Esserman and Joe Chen had come to us and said, clinically, as you can see on the left here, these patients are getting an estrogen receptor degrader and ER levels are decreasing. And we think that's due to the drug because it's degrading estrogen receptor. But when these patients go to surgery, now that ER is gone, it looks like an ER negative tumor. So can you help us demonstrate that this is actually an effect of this ER loss is due to the drug that the patients are getting and not due to a change in phenotype of the tumor? And so we were able to show that using the EOP organoids, where we were able to basically take that tumor, keep growing it in the lab, wash away the study drug, and over a short number of months, we were able to see estrogen receptor expression turn back on in those organoid cultures, demonstrating they're still ER positive. And then the other thing that Nadine has really been working on and been able to do is to actually test endocrine therapy using these ER-positive organoid cultures.
Oh, okay.
And so she's establishing a longer term organoid culturing system and can test things like fulvestrant, which is a selective estrogen receptor degrader, using this sort of ER reset methodology. And she's tested some different hormone therapies that are being investigated in clinical trials here at UCSF. So we'd be particularly excited to apply that to ILC, where I think there's sort of potentially different endocrine sensitivities to many of these agents. So to summarize, ILC organoids have unique challenges, but can still be established successfully. And we're trying to modify our culture methods to really enhance this approach. We have a protocol for resetting ER activity so that you can look at new endocrine therapies in vitro in ER-positive breast cancers, including ILC. Really grateful for all the collaborations here at UCSF, and also want to thank Michael Bruck and then Julia, who helped me as I was putting this presentation together. Thank you.
Thank you so much, Jennifer. Those talks were fabulous. I'd like to invite the speakers to come up to the stage. We're going to have a question and answer session, some discussion. I also just want to take a moment to thank the organizers of this BOP seminar. It's actually quite a lot of work to organize a seminar like this. So thank you so much to Astrid, Melinda, Ariel, Vanessa, Francesca, Emily, and then of course the leaders of our BOP, Laura Esserman, Andre Gaga, who's here, and Laura Van Beer. Both Lauras are participating online as they're not in San Francisco right now. Then I'm just going to leave this up on the screen while we're discussing. This is a QR code for if you want to submit like your information to get updates on the invasive lobular carcinoma symposium that I mentioned. This is an international meeting that we are going to be hosting here at UCSF in September of 2026. The first ILC symposium was actually held in Pittsburgh, organized by Steffi Osterreich 10 years ago, so 2016. So it'll be the 10-year anniversary of the first ILC symposium. And with that, we will open the floor for any questions or discussion. And we have some microphones that we can pass around. Looks like there's someone in the back. Jill.
Well, thank you for a really excellent session. That's so great to see all these slides, and thank you for everyone. Rita, you presented the, is it SEER data or increasing rates of ILC, right? How is that stratified by age as an increasing age in population? And did they do any sub-analysis on the ILC types? As a proportion of all breast cancers, are we seeing is it increasing in particular one sort of phenotype or?
Yeah, no, it's a good question. So I think the increase in the rates of ILC kind of parallel the increase in rates of hormone receptor positive breast cancer in general. I think for ILC in particular, we know it's a very hormonally sensitive tumor type. So some of the theories that the authors posit in their analysis is perhaps epidemiological things like delayed childbearing, more exposure to estrogens, perhaps through the environment. These are things that might be contributing to the increase in ILC diagnoses. There's also, I don't know if our pathologists want to comment on this, but I don't know if it's being diagnosed more often, like maybe there's more awareness where some tumors that were previously called invasive mammary carcinoma or invasive ductal carcinoma maybe are now being called ILC. So I think it might be a variety of factors, but it appears to be just an increase across all subgroups.
Laura, I don't know if you can hear us. Go ahead.
Yeah, I can hear you. Can you hear me?
Yes.
Yeah, okay. I have a question. First of all, congratulations for putting all this together. And Rita, thank you for your leadership in lobular cancer. I think it's just really exciting. This is definitely how we will make progress. And thanks to everyone who's jumping in with both feet. I think that as you and I have discussed, I think what's interesting is, the FAPI scan data, small that it is, does suggest that, there may be some interaction with scaffolding or, fibroblasts or whatever is, it appears that lobular cancers grow independently, but in fact, it may not. And so I don't know, Jennifer, if as we grow, one of the things, as we are interested in this, potential ADC that could get at the scaffolding. It would be super cool to test. They are looking to have some kind of evidence that these cells are there. Are the organoid cultures capable? I mean, they should be. I mean, I don't know if they're able to maybe capture some of these cells and for us to really understand, are they L19 positive or do they have that fibronectin variant that's there? Is there some way to look at that? And would there be a way for us potentially in the organoid system to even do a little test to show that this approach might be viable? I mean, or can you see, is that something you can investigate in that system?
Yeah, so I think not too long ago it would be more challenging for us, but now with the ALI models that Jose is developing, we are seeing that we're maintaining stromal populations, including fibroblasts, depending on how you modulate the medium, and we know we can test ADCs in organoid cultures, typical organoid cultures as well. So I think we're actually coming to the point where we could potentially test some tumor microenvironment targets as well. So I do think that that's possible. I think that sounds like an exciting approach.
I think the other thing, I don't know if Sandy Borowski's in the room or online, but one of the things that is challenging is trying to identify the right antibody to find these cells. And the company may have something. He's been in touch with the scientific people, but maybe you should talk to them as well. With Rita, and that might just help them get excited about bringing this into the trial.
I'm here.
Sandy, yeah. So you want to comment?
You ask a very complicated question, and I was going to start with the radiology perspective of this, which is you showed very nice sensitivity with contrast enhancement. That's vascular contrast enhancement, and we now have things that Laura just mentioned, like FAPI PET. So I was going to ask you, first of all, a simple question. What is the role or the emerging role of FAPI PET. And then we'll get back to Laura's big picture.
Rita?
I'm going to have to state outright that we don't do it, and we don't sort of, as a clinical radiologist, I have no experience with it. I think this is an open avenue. All of these tools, I think, are going to make a big difference, but we don't have them now.
Yeah, so just
But
for everybody,
but we have them for research.
Everybody's knowledge base, FAPI PET is based on a specific PET probe that interrogates a fibroblast activating protein. I think that's what FAP stands for. I don't know. And so that's a totally different kind of contrast, looking at a totally different thing, which is related to the microenvironment, which is the second part of Laura's question, which is, are there microenvironmental cues that are both targetable with therapy, but also useful for diagnostics in understanding what's going on with lobular? And I think, as Jennifer just said, we don't know yet, but yes, we can study that in a very controlled experimental model system. And that's,
well, Sandy, I think it's actually important we should set up an in-person meeting with Tom Hope, who is insistent that it's not possible that the FAPI molecules, or that the FAPI scans are recognizing the tumor necessarily, they're recognizing this infrastructure. So I think what's interesting is your stating suggests it might actually be on the tumor cell. So I think we need to try and sort this out. This is, I think, really important. But Rita and I have gotten Tom Hope, and now Natsuko's got some resources for us to do the FAPI PET followed by MAMI PET. I mean, Rita, don't you agree? I mean, there's no question that the lobulars just light up like a light bulb on these scans, or what we've got, now 6 cases, and they all light up.
Yeah, I want to give a lot of credit to Thomas Hope in nuclear medicine, who really is an expert in FAPI PET, and he's had a protocol for imaging patients with other kinds of cancers for quite some time. And so we have started imaging patients with breast cancer as well, including lobular, and it does.
We lost them.
Yeah, are they there?
I don't know. It's us. And 88, or actually we're with 88 here online, which is great. Good to see you all.
Good to see you somehow. They've kicked us out. They don't want to talk to us.
I just threw in the chat, Laura, an answer to your question to find the single cells. So Alex Marson has a system that's worth looking at to put on those organoids.
I just think I think this FAPI PET thing is just fascinating. There's I mean, that means there has to be a completely different support structure for these cells.
Yeah.
That we've just missed. And there's this company that's got an antibody drug conjugate against it. And I'm like, I just need to talk them into letting us try it. It would be amazing. So text me. Did you put that in the chat about Alex Marson?
Yeah. Alex, just contact Alex. He can tell you about survey genomics.
Okay.
I mean, it likely works well with the different biologies. Yes, ask the question.
Yeah, so sorry, I'm a research advocate. I do a fair amount of stuff on imaging. That's sort of my focus. And you're right, FAP is amazing for ILC. It looks to be amazing. One of the interesting things, and maybe I'm not a clinician, so maybe you guys can, was that it's also really good with GI in general, which is also very hard to image with nuclear medicine because of the high uptake of FDG. And so I talked to a GI surgeon at MGH who said, yeah, with GI things in general, you kind of need to look at it you need to do an endoscopy or a colonoscopy to actually get a visualize of it. So I think that's very, very helpful to think that this might be a pan cancer.
Well, so Jade, that's a very interesting observation, because the paucicellular, it's a low cellularity tumors like pancreatic cancer, some of the gastric cancers, that have these, stellate cells scattered through, and lobular, they actually are related. They have certain, I'm just forgetting the name of the cell, the C. There are certain types of cells that are common to all these cancers, and they're low cellularity, and they often have scar, or they have a certain imaging pattern. Oops, I guess we're back on with everybody.
I think we hear the audience again.
Yeah.
But so that's a fantastic observation.
I may send you an email, Dr. Esserman. I saw you at that research retreat a couple weeks ago, but I didn't get a chance to say hello.
I'll put my email in the chat, okay?
Okay, thank you.
So typically the biallelic loss is due to
maybe send us Jade. We'll reach out to you.
On one set of allele, the other allele develops a mutation in the C.
I'm very involved with the LBCA and other ILC sort of
related, but a lot of those studies have been problematic.
I love that.
Noted.
Experimental technique and questions about contamination.
If I don't answer
for your
send
question
again.
About is there a contamination about between lobular?
I got a lot of email and I missed some. I'll look for it though.
Invasive lobular, but as we discussed in the case for the cure on this past Saturday, they are
We can't really hear them.
I'll tell Astrid.
ALH and LCIS are actually considered risk factors for bilateral breast cancer rather than a direct precursor, whereas DCIS is thought as a direct precursor. But from the clinical pathology perspective, honestly, the two don't necessarily have to go together. LCIS does not, you don't need to have LCIS in the background to have an ILC there. And you don't have to have DCIS in the background to have an IDC there. So there is something that it's not a direct linear path, and I don't have a good answer for why.
So I was going to comment that this central model of Egyptia, we talking on type 2 engagement, it's probably not even true in detail. Very uncommon for DCIS to progress. It's much more common to see coincident DCIS with invasive. It's a nice single cell RNA work from Nick Navin group. It shows that they are indeed coincident. They occurred at the same time together in parallel, not one leading to the other. And I think in ILC, there's no clear evidence from epidemiology that lobular carcinoma in situ progresses to invasive lobular. We do see them coincidentally sometimes. So I hate the term. Yeah, they share that in common, correct. And so what it means that we know, and we know this actually from mouse models, is knocking out interferon is not there have to be other factors. And so, the NKI group knocked out interferon and then they got tumors that looked a little bit like lobular. And based on a molecular definition, they are. So I think that we have to think a little bit different about our conceptual model of this progression, the Vogelgram, if you will, of accumulation of molecular changes that accompany these morphological changes. And think about what are the origins of invasive lobular. I think it's a really important question. I like the YAP idea to put it out.
That was my follow-up question is that maybe when there's different types of ILC and then have different pathways, right? The unmarked ILC have different communications, might be one HER2 activation, and so have all the different subjects to show have different sort of secondary pathways to get to.
And there's also work from Sarah Kane showing that for patients who have
LCIS and ILC concurrently, that the two lesions do contain the same pattern of genetic mutation. I think one of the things that makes the research really hard to sort out is that sometimes when you have the diagnosis of LCIS on a needle biopsy, there is already the cancer that you only discover upon excision. So I think some of the literature is it's complicated to say, did they occur at the same time? Did the LCIS progress to ILC? And as has been pointed out, we typically think that LCIS has a risk factor for developing cancer, even in pockets of breast, but not even necessarily ductal cancer. So I wonder if it again comes back to the stroma. There's something about the environment that is allowing these globular neoplasms to form.
Hey, can we use breast MRI in pre-surgically in lobular carcinoma disease treatment? Yes. 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 Obviously, I mean, one of the things that you're working here is this. We as experts, and we can do it because the reality is MRI has the highest sensitivity, but we know it's only field specificity. So it is the best tool we have to surgically plan and make surgical decisions, but it is far from perfect. We know that ER-positive cancers, which we essentially are their MRI is weakest in those compared to triple negative, where if the preoperative MR is negative and triple is clear in a triple negative case, you can be very confident points the OR. Where that is not true in ER-positive cases, these cases included. So we do our best, and it is the best test we have, but it is far from perfect.
I have a follow-up question about overestimation of the dimension of tumor burden, and perhaps maybe cDNA can help with that.
I mean, during Rita's opening and your lecture, I had a million questions. I'm so interested to see where the imaging and ctDNA are complementary and where they diverge. And I think both of those will be important things to identify. Rita was talking at the beginning about these discordant cases where their clinical story and their genomic stories don't necessarily, their prognostic genomic stories don't match. And right away, I'm thinking, well, what does the imaging look like in those cases? Do the patients who don't clear their ctDNA at 2-3, what did their MR look like at 2? Right? And could that help us further stratify these patients? I think that's really the box question. Which is
Can we ask a question from here or not?
I don't know. I was just trying to say that failure of ctDNA to clear at 6 weeks may be a more
universal.
Yeah, we have to work on that, you know.
I have a question on subtypes.
By the way, did you see the thing that I sent to the cancer cell editor?
Yes, I have something to add.
Okay.
Great.
We didn't exactly talk about it, but like that, you should write up the.
Yeah, I have two other things also.
Okay, just add it. Just reply. Just trying to get it out.
So
did you see my email on the FDA thing?
Not yet.
Really? Were you not on it?
I don't think so, but I was. It could be me.
No.
Right. It got lost in the
internet
air.
I didn't send it. Let me see what time I sent it.
I get a text message. Will soon be better on the Zoom. Oh, I have to do something.
Bye. Okay, I'll send it to you, okay?
Cases, you can find people with lobular tumors who are going to benefit from chemotherapy. The challenge is that not very many patients with lobular tumors have mammaprint high risk. So I think that's why it's so important that the study that you are the PI of, the EOP study and I-SPY, is first testing endocrine therapy to see whether or not that is an effective strategy to get enough response in these tumors. And if that is not adequate, then maybe those are the patients in whom we need to add chemotherapy after surgery. And as you can explain better than I can, I think the real challenge is how do we determine whether or not the tumor is responding? Should we use imaging? Should we use ctDNA? Should we use RCB, PCR, Ki67? So I think that those are really important questions to answer.
Rita, in that study, though, if you control for the mammaprint, I mean, they were all mammaprint high, but if you just look at ductal versus lobular, did it look different? Right? If you take out all the other clinical factors we use, is there something about lobular that makes them less chemosensitive? And I feel like we all in our gut feel that they are, but these studies have not shown that. Is that right?
Well, even there's some studies showing that even in triple negative and HER2 positive lobulars, that maybe there's like a slightly lower response rate compared to the equivalent ductal tumors. So perhaps there is a little bit less chemotherapy sensitivity, but then there's other data showing that especially for higher stage lobular cancers, there is a survival benefit. So it is an unanswered question. I think really, really important to look at.
I was just going to say, my understanding is that OncoDX, in contrast to what you described for mammaprint, really underestimates risk with ILC. Is that?
Children 4915.
Yeah, I don't know. I think we just have a lot of mammaprint data because of I-SPY, and I do think that the majority of lobular tumors will be classified.
Oh, did we lose you again? Did we lose you?
Maybe they went on mute during the announcement.
4915.
Thank you so much for all of this. It's such a great discussion.
Great. I think one of our clinical challenges for patients with metastatic lobular cancer is many of our clinical trials require measurable disease, where you have to be able to measure it. And as you all know, with lobular cancer, often this is bone only or in the lining of things where we can't measure it. I guess in the ideal state, would love to hear from you, like with a novel imaging, with ctDNA, like how would you design a metastatic trial that kind of better captures this and to be able to include these patients in our trials?
Maybe FAPI scans.
Others may want to comment on this, but I will. We'll just wait a second.
4915 hospital, 4th floor, children's cardiac intensive care.
So we have actually looked at enrollment rates on clinical trials for patients with lobular versus ductal cancer here at our own cancer center. And interestingly, if you look at patients with stage 1 through 3 breast cancer, the same proportion of patients with lobular are enrolled on trials as ductal relative to their prevalence in the population. But when you look at patients with metastatic cancer, we enroll significantly fewer patients onto clinical trials. And I think, as Dr. Hubbard is pointing out, this may be related to the fact that the majority of trials for patients with stage 4 breast cancer use RECIST criteria, which requires that there is a site of disease that you can measure, like with a ruler. And if you have a diffusely growing tumor like lobular breast cancer, the metastatic site might be diffuse involvement of the layer in front of the intestines in the abdomen, or it might be a pleural effusion or fluid around the heart, or something that you just can't put a ruler on. So patients with that kind of unmeasurable disease are not allowed to enroll on many of these clinical trials. So if we could find a way to make an objective indicator of how much tumor there is in the body and whether it is responding or not responding to a given treatment, then that objective endpoint could be used to design clinical trials. And that was the impetus for the Plum study, where we are getting circulating tumor DNA at the time of standard of care imaging. And our hope is that by using a highly sensitive assay and quantifying the amount of tumor DNA in the blood, that we'll actually be able to see dynamic changes in the quantity of tumor DNA that actually reflect what our medical oncologists are saying, because our medical oncologists are making decisions every day about whether a drug is working or not, whether they're going to be changing a patient's treatment. And they're making those decisions using their clinical experience and gestalt and interpreting the imaging with a radiologist that is very, very hard to do in an objective fashion. So I think ctDNA and better imaging are really important to develop for patients with diffusely growing tumors like lobular. I don't know if anyone else has.
In the neoadjuvant setting, I think the I-SPY2 data will be very important. So right now we have 65 patients, as I presented, but we're going to double the number of patients with ctDNA data by the end of the year. So we'll have, by extrapolation, double, and so that we can use to actually look into the predictive value of ctDNA with regards to response to neoadjuvant therapy.
But Mark, that's in the neoadjuvant. I'm talking in the metastatic setting.
Yeah.
You know, because lobular tends to grow on these serosal surfaces and along the vessels and places, it doesn't form a mass. Again, I think the idea of using FAPI scans, and maybe Rita in the Plum study at specific sites you could incorporate in. We could try and figure out how to get like a little additional money to make sure that you get a FAPI scan. But let me give you just a little advice from the Type C meeting we had yesterday with the FDA. I think that they are very open to adding in these robust early endpoints. And let's face it, RECIST is stupid. We have so many better things, ways, functional tumor volume or ways of measuring volume are so much better, but things that are very established are very hard to change. I think having a robust early endpoint, the FDA is open to it. The kind of study you're doing, this Plum study, is going to be landmark for this. You want to generate the data, and they said, give us an answer, right? So this is perhaps where ctDNA could be extremely useful, although we also know it may be lower. I would try and add in the FAPI scan as much as you can. And what the FDA also advised us is if you have a new idea, you can have a hypothesis that you can then request to be incorporated into future studies, and you need to bring the community along with you. And we're going to do a workshop on just this issue. Maybe I can figure out how to sneak this in some way along with it as a session at that workshop. I think it's a very cool idea, and I think you're thinking just right. Again, you may or may not have ctDNA and all your lobular cancers, but you probably will have a positive FAPI scan, but we don't know. So you got to test it and see. But there's a process they want you to go through to bring new things to light. It takes time and it feels frustrating, but if you do it a year or two, it could just be transformational.
I have a question about the criteria. I was wondering if there is any looking at using AI to quantify, for example, innumerable diffuse sclerotic bone mets or something like that, because I know that in pathology, they can, count the exact number of cells on a slide and come up with, or the exact percentage of staining. I know it's probably in development, but I agree with you about the FAPI. I also think that there are a bunch of other novel tracers that are coming online that might be good. And I also know that there's the PERSIST, and just even including persist criteria is helpful. I also think that there was an effort to look at this issue, maybe with the European Lobular Breast Cancer Alliance. I'm not sure. I'd love to know more about all that.
Yeah, I think that those are great points. I think there is ongoing work using AI and imaging that I don't think that we're familiar with specific studies looking at metastatic sites in lobular, but that may be ongoing. In Europe, I think there have been some groups that have focused on whole body MRI as a way to maybe better characterize metastatic disease, specifically in patients with lobular breast cancer. Yeah, Elissa.
Yeah, I mean, I think sort of shows that from a systemic point of view, this I think very much is becoming a nuclear medicine issue, so it's different than breast imaging. But the room there is tremendous. In a breast imaging point of view, AI is coming. I mean, for all of us, AI is coming. And I think it has really interesting implications in how it could help us. I think even at Rise Up, we'll be talking about that in the imaging session, so plug for Rise Up.
Great. We have some questions from the Zoom. The first question was from Dr. Laura Vampier. I think it's for Dr. Ye. It's how often is ILC a mixed type of different ILC subtypes?
I think actually most of the ILC cases are mixed classic and something else.
What about ductal?
The ductal thing is a little controversial. Again, depends on who's making the diagnosis.
Great. And then a follow-up is from Ronald Balasnin. It's for Dr. Ye as well. It says, fantastic presentation. The variability in IHC staining for identifying the ILC is concerning. Do you think the NCCN or WHO should select one antibody for e-coherent staining universally? Do you see parallels to HER2 staining?
I do think that's a great suggestion. And HER2 staining, you may know there's two currently FDA-approved antibodies. One is the Vantana 4B5, which is what we use here at UCSF, and the other one is the HERCEP test. But because there are rules, the FDA rules about laboratory-developed tests, it's not required for clinical laboratories to use exactly what is FDA approved or a specific antibody. A lab just needs to demonstrate equivalency to the available approved tests. So for example, SFGH, Brigham and Women's, they actually don't use any of these FDA approved antibodies, and that is okay. So that this would lead to a question of how do we regulate laboratory developed tests, and this actually has been a very hot topic in the realm of pathology and laboratory medicine, because restricting the development of laboratory developed tests and giving room to the different labs, clinical labs around the country to develop new tests and use quote unquote off-label antibodies will also, or other reagents, will actually limit their ability to create new tests and make new developments, such as the fast developing COVID tests that we were able to make because of that flexibility in laboratory developed tests. So it's a little bit complicated and gets into regulatory problems that you might have bigger implications than you think than just setting up a good rule for how to diagnose ILC.
I have one last can of worms though.
Hopefully maybe this is the last question because I know we're over time. Is invasive lobular different with respect to immune recognition, immune evasion, and of course immunotherapy?
I think my understanding is it's an emerging area. There isn't, I think it was just presented at San Antonio. There is actually more of an immune infiltrate in ILC than IDC, I believe. But I think whether, and to what extent that can be targeted remains to be seen. Rita knows.
No, I would echo that. There's very limited data, but I think there's some work using the Boston gene assay, which is looking at different cell types that have shown an immune infiltrate, which is maybe more than expected since most of these tumors are ER positive, HER2 negative. And I'm not really aware of data on immunotherapy and lobular cancer specifically.
So it's
it's more like comments. So I'm a statistician, works with Rita. So my comment is that I think this is sort of the types of the disease. It's rare. So I think there's a registry can play a great role. Like, for example, that not all that the clinical trial needs to have that the control arms, or the registry can serve as a platform to share that some information and then data useful in that way. So I'm just wondering that how much of effort is getting into the have that such a registry, and then how much of the molecular information can be shared in that kind of platform. Potentially can be utilized in that to make that the clinical trials more efficient in future way.
Thank you so much for that comment. I think it is rare and not rare. I think if you look at the absolute number of patients with lobular breast cancer, it's something like the 5th or 6th most common cancer overall, just because breast cancer is so common. But it is true that at any individual center, you're not going to have these huge numbers of patients with lobular breast cancer. So doing multi-center studies is very important. That is why when we designed the PLUM study, we made this a multi-center study. And there are groups, advocacy groups, the Lobular Breast Cancer Alliance, there's a European advocacy group, there's different centers in the US that have focused on lobular breast cancer that are leading these efforts to try and encourage collaboration across sites, because I do think that that's the direction we need to go in.
And Rita, I think also you may be able to define a group of hormone positive cancers like the ductal lobulars or whatever, the people who have more of this diffuse tumor on like where we can define it on MRI, that in fact lobular may be part of a spectrum of these more diffuse tumors that are somehow dependent on the stroma in different ways. And that group may be quite a bit larger than we think. And so you can also kind of from the reverse kind of expand out what those features are of those more diffuse tumors that are less responsive in general to chemo, and figure out what they really need. That may be actually another really important direction.
Absolutely. So I want to thank everybody for coming, and we will wrap up as we're over time. We really appreciate all the people who came in person and who came on Zoom, and hope that you guys enjoyed this session where we're recognizing lobular breast cancer. So thank you so much.